Our next speaker, I'm pleased to introduce Dr. Corey Waller. Dr. Waller is an addiction, pain, and emergency medicine specialist in Grand Rapids, Michigan. He works within the Spectrum Health System, a fully integrated health system with 11 hospitals and over 1,000 employed physicians. He is the medical director of Spectrum Health Medical Group Center for Integrative Medicine, the medical staff chief of pain medicine to the Spectrum Health Hospital System, the president of the Michigan Society of Addiction Medicine, as well as medical director at Lakeshore Regional Partners Community Mental Health Region 3. Dr. Waller earned a Master's of Science in Neuromolecular Biology at Southwest Texas State University and earned his medical degree at the University of Texas Medical School in San Antonio. Dr. Waller completed his emergency medicine residency at Thomas Jefferson University in Philadelphia, and his special interests include understanding the biopsychosocial and financial impact of high-cost complex patients, pregnant patients with a substance use disorder, and the complex interaction of pain and addiction. Dr. Waller.
Morning. So this is going to be really difficult for me because I'm normally like a walker and use my hands, so this is going to be, I may have to pick this up, and I always wish I got the Bob Barker mic, you know, the really long skinny one.
You take the mic off?
You can do that?
Yes.
Then I can't use my hands. It's going to be like a broken chicken wing. So one thing I will not do is I'm not going to make fun of Jackson, because then I'd have to be put in my car and out of town. I don't want to do that. That's not going to happen. I am actually going to talk bad about the medical profession, though. So I will, since I am in it, I will absolutely start to dig in on some things that we've done a poor job at. But I think the goal today is first I need to find out who's in the room, because I don't use PowerPoints anymore. I had 10,000 of those through graduate school and medical school and all of this stuff. And what I really want to know is who's here, so that I can speak directly to who's here. And make sure that we understand if you're in law enforcement, or if you're in the judiciary, or if you're in treatment, or if you're in treatment as a person, that we can make sure that we level set the knowledge about this, because I think that's one of the biggest issues that I found in not only treating patients with addiction, but then in trying to develop policies and procedures and pathways and guidelines for addiction, is making sure that we at least create a common vernacular that we can all have, and we can all have the same discussion. Because when I say addiction, I want to make sure that you understand what I mean by addiction. When I say substance use disorder, when I say medically assisted treatment, when I say that, what those really mean and what they mean to me, and what they should mean to the state and to the nation, which is what we're working on now with developing these national policies, state policies, and the ability to get actual value for what we're paying for, in a sense that if I give you $1, I want to know that the person we're giving that treatment to is actually getting good treatment, and not just getting a prescription, or not just getting a chit-chat, because those are things that don't really end up giving us what we want. And if we just apply the evidence that I'm going to talk about to the disease that we're going to define, we can actually get 75 to 80% of our young people who are addicted to heroin off of heroin and functionally right back into society where they needed to be. 75 to 80% is where that sits, just by using the evidence. And so to think that once you're there, we can't get you out, it's just not the case. So how many people here are caregivers, in a sense of they actually work within the medical field, either as a therapist or a physician or a PA or a nurse practitioner or any of the above? Great. How many are related to someone with the disease of addiction? Right. If you didn't raise your hand, you haven't seen your family enough. How many of you are, at this point, within the criminal justice system? And in the judiciary specifically? Lawmakers, or those that work within the state, or community mental health, or any of those from an administrative standpoint? Great. All right. So what this means is that we have everybody that you kind of need in the room to make a decision, which is important. And what I'm going to teach you over the next 45, 50 minutes is the same stuff that I teach my patients. So Any vocabulary that I use, any neuroscience that I teach, all of my patients leave the office knowing these. They understand the lateral bed nuclei of the amygdala. They know what the nucleus accumbens is. They know what the static dopamine level in the nucleus accumbens is supposed to be. They understand that when we give an SSRI, that is to specifically treat serotonin, which is to help treat sad depression, but not necessarily anhedonic depression. When we talk about educating yourself, you have to really educate yourself if you want to understand a problem. We did get some Robert Wood Johnson Foundation funding, and in February we'll have a website available that's for free. We got about 40 hours worth of training, and that'll be February 1st is when that'll go live, and it's complex.care. And so that's built for everybody from the patient all the way to the specialist. But I should say now that I've given, I guess an advertisement, I don't get any money from drug companies. I get no money from this. I get a paycheck every 2 weeks, no matter how many people I see. Anything I get paid for talks goes straight back to Spectrum. I don't get any of that. So this is something that I do because I think it's really important. And actually my Spectrum Health thinks it's important, and I think you guys do because you're here. So let's talk about the brain, the neuroscience of this, so that we can understand what that means. So some of you have heard this, so I'll apologize. We've morphed this talk over a period of time, but you need 3 things to survive, right? You need food, you need water, you need dopamine. So dopamine is this chemical in the middle of the brain that tells you in the morning to get out of bed and to go get your first, second, third, or fourth cup of coffee. It's the thing that when somebody pats you on the back and tells you you've done a good job, that you're going to go and actually do a better job. It's the thing that creates motivation, that internal drive to do something different. And without it, you're not really able to do the next best thing. We know enough about this in the area of the brain that this resides in the nucleus accumbens to now know that this is the final common pathway for all addiction, whether it's a behavioral addiction like gambling, whether it's an addiction to heroin, whether it's marijuana or alcohol, it doesn't matter. The final common pathway is at this area of the brain called the nucleus accumbens, and it has to do with dopamine. So when we start to look at this, we know enough about it now that we can tell you what you should be at a normal level, like a daily level. So if I look at your brain, and we've got this information based on sticking little pipettes in brains and measuring exactly little microgram doses of dopamine, and then we don't do that in people. That wouldn't work out well. But now we have functional MRIs, so we can look at the brain working and we can see what this looks like. So we've been able to define what is normal versus severely abnormal versus something that is just above what it should be. And because of that, we're able to know what is happening to the brain over time in the disease of addiction. So our normal level of dopamine is right around 50 nanograms per deciliter. All right? That's our wake up in the morning. It gets you up out of bed. It gets you to work. It gets you to school. It gets you to get your kids ready. This is what happens on a regular basis. So with that 50 nanograms per deciliter, you can do what you need to. On your worst day of your life, it's like 40 nanograms per deciliter. This is the day that you're at home and you don't want to go to work, so you call in and fake vomit on the phone, and you're like, I cannot go. You make whatever excuse. You never even get out of your pajamas. If you're me, you sit in the basement and play Xbox and don't tell anybody, or you just do nothing all day. Best day of your life, the day that you win the lottery, you got 2% body fat and you own an island all at the same time. It's like all of that happens at the same time. That's 100 nanograms per deciliter. That's the physiologic max. That's the amount that our brain is supposed to make at maximum, because it allows you to actually make still logical decisions despite being super happy. Best food ever, 94 nanograms per deciliter. Sex is about 92 nanograms per deciliter, so bummer, right? Food totally outweighing that. So that's I still think there's some variability in that research we need to figure out. But as we have that, this is where we're supposed to live. We're really supposed to live between 40 and 100. And that enables us to work within a society and people around us and be motivated and have good outcomes and positive interactions and really allow us to be human and to have that feeling of normal and fitting in and excitement. So what happens if somebody uses something like methamphetamine? So if they smoke methamphetamine or inject methamphetamine, that then takes that dopamine level from 50 to 1,100 nanograms per deciliter. So all of a sudden, we've gone from our maximum being 100 to it cranking it up to about 1,100. Heroin's about 975. Alcohol's in the high 800s. Marijuana still in the high 600s. So it's still hugely above what it needs to be. So the body doesn't like that. We have innately in our system this desire or ability to create and maintain what we call homeostasis, which is a term that means I want to be what I want to be. And if it's meant to be here, I'm going to fight back so that whatever it is, whether it's a calcium level or a potassium level or a dopamine level, it doesn't matter. The body's going to try to get it right where it needs to go. So when that happens, what we do is if somebody uses this drug once, they get that 1,100 nanograms per deciliter. The next time, they'll never get it again because the body immediately compensates. So an hour later, if they tried it again, no go. Because the body has already shut down the amount of dopamine it's going to release. So this is that chasing the dragon concept that we talk about, trying to get that first high. They will never get it again, ever. The brain has now turned off that as your maximum, permanently. We can't even find that it ever goes back to that capability again. So let's say they continue to use this, and then all of a sudden it's 1,900, 700, 500, 300, 200, 100, and now even when they use the drug, they're still only having what we would see as a physiologic normal best day. That's a real problem when we have what we call success, right? When we have someone that we have grabbed, pulled away from, detoxed, and gotten them into treatment. Now what have we done? Well, what we've done is we've taken someone that even when they're using the drugs on a regular basis, they're at 100. When we remove that from the system, now their best day ever is 30 or 20 nanograms per deciliter, which is far below our worst day. So the interesting thing that we find out is that dopamine is also required for us to be able to onboard emotional memory. And so what is therapy? Onboarding of emotional memory. That's all it is. It's the recognition of a thought and creating a new behavior, which is what cognitive behavioral therapy is. And that requires the ability for the brain to onboard a new emotional memory. So when I feel this, I do this instead of the other thing that we're trying not to do. Without dopamine, you can't do that. So when we put somebody in therapy with a low dopamine level, what we get is someone who hears this. They get nothing from therapy early on if that dopamine level is not stabilized. So this leads to a really common concept of craving. If you don't have enough dopamine and your body requires dopamine in order to be motivated to do anything, get out of bed, put your clothes on, get your kids ready for school, even care to go look for your kids. I have a 3 and a 5-year-old, so I now have, you have those freak out moments, right, where you're like, well, they were right here, and now they're not. And then you have that little internal panic of, well, I think we're okay, but then all of a sudden you're not. That feeling doesn't occur without dopamine. That is a dopamine, adrenaline, norepinephrine response. That axis does not exist in a person with an abnormal dopamine. So when we get there, the body knows that this is not right. And despite this use of drugs that's now declined not only the release of dopamine, but over time, an actual shrinking of the nerves that release dopamine, followed by a killing of those nerves if you use long enough and high enough doses. So the body will go through this whole process that we call in science apoptosis, which is what we call programmed cell death. And it basically starts to slowly and systematically kill the neurons in the brain that are responsible for making dopamine. When that happens, that is the equivalent of a stroke. Those are dead. They do not come back. And so there are some patients who will have literal permanent damage to the happy part of their brain. And this is what we call that anhedonic depression. Anhedonic depression is a flat depression. It's not a cry in the corner depression. It's an I don't give a crap depression. It's a your house is on fire. Like, all right. Here's $100. Okay. You're going to go to jail. Whatever. I mean, that's the response that happens. There's no capability to motivate, even to create an emotion, let alone to do things that we want them. And yet when we tell somebody, you just need to motivate. I mean, that's honestly like telling someone, with no hands, just grab it, you'll get it. It doesn't, it's just not capable of happening. I mean, we're telling them to do something their brain is incapable of doing. And that is a reason that appropriate, highly aggressive early therapies, as well as medication-assisted treatment, help to stabilize the dopamine axis and decrease that craving, not for the drug, but for dopamine. So if we want dopamine, and we've looked at this from a functional MRI as well, and we've looked at what craving really means. So we know what parts of the brain craving lives in. So it lives in the anterior cingulate gyrus, the frontolateral, frontal lobe. It lives in the lateral and central bed nuclei of the amygdala. We know exactly where in the brain it is. There's a test at the end, and you can't leave until you pass it. But we know so much about it, we know exactly where craving is, so we can track it the same way that we track the basic static dopamine, which is with a functional MRI. And so we've done these tests to look at people who are starving, who are severely dehydrated, and then that group of patients who have had their dopamine axis really beaten up by drug abuse. And so Dr. Apkarian and Dr. Gardner did this really interesting study where they took people and they didn't have them eat food for 5 days, and then they didn't have them drink fluid for 3 days. So 3 days of zero fluid intake and no IV fluid. So that's really pretty profoundly dehydrated, meaning when they stood up, their heart rate would go up really high, they would get very dizzy. For food, I mean, their blood sugars were just barely hanging around 60, and they felt like dizzy and nauseous and just not right. They would give them fluids, and then they decided, well, let's see what their brain does when we offer them these things that they haven't had. So they take a group of patients, they were actually medical students and volunteers, so, the group that you beat up on for more than one reason. But as they go in, they had them say, what is their favorite food? So beforehand, they said, what is your favorite food? And they'd put them in the functional MRI after 5 days of no food, and then they would ask them, tell me about this food. Let's talk about it. Let's walk through this. And then they would bring the food into the MRI suite and waft it into the MRI tube. And then they would let them kind of taste it but not eat it. And then they would functionally MRI the brain to determine how much craving was for food in a starvation state. And what we found is that the craving was kind of a relative size of a basketball. All right? Not a literal basketball, because that's bigger than your brain. If you have a brain the size of a basketball, good for you. I hate you. But as we look at this, we have to look at also the starvation state. That's about that big, right? And then we looked at the state in which you're so dehydrated that you can't even stand up without somebody's help. And we've looked at them when we talk about water, and they would splash water on their feet, and they would play water sounds in the background. And then they would let them taste, wet their lips on the outside, but not let them drink. And they were looking at their brain. And this was a relative size of a baseball, right? So even smaller than food. So food, we have a higher level of craving to get. And we've seen people do really crazy stuff in a starvation state, right? We look at, in natural disasters, and people, will do some really odd things. They'll steal, they'll hurt other people. I mean, if I walked across a desert for 3 days and I didn't have anything to drink, and you put a glass of water in front of me and said, you can't have that, I'd be like, oh, and stab. And then I would just take the water and I would drink the water, right? I mean, and I would think nothing of it. I'm like, oh, that water's so good on my mouth. And that would be it. I wouldn't be thinking about any of the other stuff. But when we look at that, and then we compare that to people who had been clean for 30 days, 60 days, 90 days, 1 year, and 2 years. I'm only going to talk about what it looked like at 1 year because the brain didn't look any different at 30, 60, 90 days, or 1 year out from being clean. When we look at that and we put a patient in the tube and we ask them 3 basic questions. Tell me about the first time you used. Tell me the last time you used, and tell me the one thing that you really liked about using. And we looked at their brain, and we looked at it for, again, 30, 60, 90, and 1 year. That was the relative size of a baseball field as compared to a basketball for starvation and a baseball for dehydration. So this is what the brain has to really overcome on a daily basis. And it's a voice that is so loud in the head that there is almost no way to not hear it. You can't just turn that off because the body and the brain sees this as pure survival. And so it was said earlier that the first pill is a decision, or the first drink is a decision, or the first time you smoke tobacco or marijuana, that's a decision. Usually made at a time when you don't make good decisions, right? This is between the ages of 12 and 16 when most people have their first introduction to a substance. You know, it took me till like 34 to make a normal logical decision as a man. So I don't really understand how we can be held responsible for that decision at that point in time. But after that, the dopamine level gets messed up based on all of those factors. And we have a genetic predisposition. So there's a group of people, if you have a first-degree relative with the disease of addiction, you are 50 times more likely to have addiction than someone who doesn't. I mean, what do you do with that? I mean, there's our prevention right there, is just basically understanding risk. If you have a parent who smokes, that's addiction. That's nicotine addiction. If you have someone who drinks too much to the point where they meet the criteria for addiction, is the criteria for addiction a positive urine toxicology study? No. If someone has cocaine in their urine, are they an addict? No, they're not. They have cocaine in their urine. If somebody has heroin in their urine, are they an addict? No, they're not. What you use to determine that are the behaviors, right? So we have 11 criteria, 9 of which are behaviors. Only 2 have to do with dependence and the way in which that's used. And so basically you have physiologic dependence and withdrawal and 9 behaviors associated with it. And that is the behaviors associated with how the drug interferes with your interpersonal relationships, how the drug interferes with your relationships with society, and how that drug puts you in dangerous, areas, whether or not that's physical harm, being in a bad location, or actual harm to self, knowing that it's causing that harm. That's how we define it. So we need to be clear that as we're defining the disease, this disease is defined based on behavior, not a urine drug toxicology study. Now, someone with a positive heroin is not usually someone who's like, yeah, Saturday I just used some heroin, but I'm good. That's generally not what's happening. So it absolutely increases risk to the point that we have to worry and dig in. But at the same time, you can't immediately make that assumption. So if we define the disease based on behavior, why is it that when the behavior gets worse, we actually kick them out of the system of treatment? So as the behavior escalates, you get booted out of a primary care practice. As the behavior escalates, you get booted out of the emergency department. As the behavior escalates, you can even get fired from community mental health. I mean, I've seen this kind of stuff happen, not only in our state, but around the country. And so this doesn't make sense, given that if someone shows up to the emergency department, status post an overdose, meaning that they were brought in because they overdosed either on alcohol or opioids, but particularly opioids, their risk of death in the next 30 days is higher than that of a heart attack. But what do we do with a patient who comes in with what we call a non-ST elevation MI, which is a heart attack that the EKG doesn't freak you out, but they're releasing a chemical from the heart that says, I'm being injured. So we see that in a lab test. That person does what? We send them home and say, follow up with your cardiologist in a month and good luck trying to find somebody to write you a beta blocker? No. We admit that person overnight, at minimum, to do serial labs, and then we follow up with a stress test in the morning, and then we follow up with a cardiac cath if they need it. And then they get cardiac rehab and nutritional training and in-house nursing and a building that says heart center, on it at these places. So this is different than what we do for the patient who shows up to the emergency department after an overdose, right? What do we do with them? Gomer, get out of my ER, right? This is what happens. And I am as guilty as anybody else, being trained in inner city Philly for emergency medicine and then coming to West Michigan to work in the emergency department. Those are very different, by the way. Knife and gun club to my back hurts club. That's more what we see in most emergency departments in the world that aren't high urban areas. But what I found by treating this, and you may have listened at the very beginning, what I do now is I have a clinic that's not an addiction clinic, but it sees patients who are in the ER 10 or more times per year, or admitted to the hospital 3 or more times per year, or pregnant on a controlled substance. But if I even remove my pregnant patients and just look at those that are in the ER 10 or more times per year, 85% of those have addiction. So by de facto, I ultimately run an addiction clinic, but it's not a regular, normal referral addiction clinic, but it sure feels like it when I go see patients, because that's mostly what we're seeing. And this comes down to what was talked about earlier, is how did we get where we are? We understand the neurobiology now, at least the basics of it. But how did we get here to the point where this is killing more people than car accidents? I mean, and then if you look at gun violence, which is right behind car accidents and about to overtake it, and by the end of the year, I think it's actually going to overtake car accidents as well. If you look at that, how much of that is actually related to the drug trade? Greater than 80%. So if you add gun violence related to the drug trade and overdose, that ends up being by a factor of 3 higher than the next leading cause of preventable death. So we have gotten to the heroin epidemic specifically because we're no stranger to alcoholism. That's still the number one by far. You can add up every other addiction, and it still doesn't equal the number of people with an alcohol use disorder. So we can't forget that one. But the reason that we're focused on the opioid use disorder is because it's killing people now. And it's not the 70-year-old person who has liver failure and this. It's the 22-year-old who used 4 times. It's the 33-year-old mom who dies. It's the 16-year-old who got hooked on heroin because their neighbor just happened to know somebody who could get it when they ran out of Oxy. I mean, these are the things that is why it's in the news at this point. So as we look at this, where did that start? And as it was stated, 70% of people who started heroin had their first interaction with an opioid. So 70%, 7 out of 10 people had their first interaction from an opioid from a prescribed opioid. Prescribed. Who prescribes opioids? Us, me, doctors. So I see this as, without question, the largest iatrogenically caused conundrum in our history. Iatrogenic means caused by us. If I stick a needle to do a biopsy and I accidentally puncture a lung, that's iatrogenic. If I accidentally, while I'm doing surgery, perforate your bowel, that's iatrogenic. If I write you a prescription for opioids, not asking basic questions, and you overdose on those opioids, it's iatrogenic. I caused it. Why it is that we're not swooping in to fix a problem that we have now caused to be the leading cause of death in not only our state but the country is, I still don't know. I mean, I still have conversations with room filled with medical professionals talking about this, and then I'll get a comment, well, what if the patient complains? And I'm like, really? Imminent death or angry for a minute? Because, I mean, if all you say is, wow, there's no data to show that long-term opioids actually does anything positive for you, so, it really could kill you. If we had that conversation about a blood pressure medication, there wouldn't really be a lot of complaints, right? And I bring this up because this is this weird interplay between the medical system and patients nowadays. It's turned a little bit into customer service to the point where we've stopped making sure that what we're doing is decreasing risk and not increasing risk. Increasing function and not just increasing happiness. So if we think about pain, and the crossover between pain and addiction is complex. But if somebody comes in and they're complaining about pain, the vast majority of the time, only 20 to 30% of that is actually pain, meaning the signal coming in from the injured area to the brain saying this hurts. The remainder of that is the suffering component of pain. How we react to that pain is called suffering. If I take a Marine Corps sniper and I shoot him in the leg, he will finish a mission because pain is just pain. He's not going to cry. He's not going to curl up in a little ball and cry in a corner and be all sad about his pain. He's going to go out and finish the mission, right? I can't expect a general person who walks into my office who, is like a truck driver who broke his femur to just finish the job. He's gonna require a little bit more. But then we start looking at other things of why are patients suffering so much with their pain? And part of it is expectation, and the other part is what's happened to them early in their life. So when we look at the vast majority of people who have pain and really a lot of suffering associated with that pain, what we find is that greater than 90% of them have what we call early life trauma or adverse childhood events. And so asking a basic question of, so when you were 12 years old, did you live with one or both of your parents? Did either of your parents ever come home really angry and, and possibly, hit you or spank you really hard or shove you in a closet? Or then we get into other stuff like, were you sexually abused? Were you molested? Were you that? And then we find that greater than 90% of people who are treated for opioid use disorders or alcohol use disorders have multiple of those questions answered yes. So asking those basic questions also gives us that. But who asks those questions? What percentage of primary care offices actually screen for risk of a drug use disorder? Less than 10%. Who's the number one prescriber of opioids that people overdose on? Primary care. Who's number two? So you know, but dentists. You know, so not only do they like drill in our face, which like freaks us out, but we also have this problem with prescribing controlled substances to a very high degree for things that probably don't need it. So we are where we are, right? We're here. We have more prescribed opioids than the planet combined. We consume 95% of the world's Norco, hydrocodone. So good for us, right? We can't be number one in like literacy, but we can totally take them out when it comes to to Norco prescriptions. So how many of you know of a physician in Jackson or a PA or a nurse practitioner in Jackson that prescribes, in your mind, too many of these? How many of you have called the state on them? How many of you have written a letter stating that this person is making my community worse? One, why aren't you all standing outside of the licensing and regulatory authority in Lansing with a sign? This is the question that I've asked many times, and I turn them into the point where they're having to hire new cops. So the reality is you have the capability to stop this in your own community purely by using the information you have and holding people accountable for the behaviors that they show. It is okay to hold someone accountable. It is not a question in my mind when I review a chart for law enforcement about a person who's been writing prescriptions that 85% of the patients in that office have opioids, Xanax, and stimulants to keep them awake from the opioids and Xanax. That's not okay, because how many of those are actually being taken versus sold? You know, we even talk about in the treatment, which we'll talk about in a sec, that if you overprescribe in the treatment of opioid use disorder, that middle dose is sold. If they're positive for marijuana and cocaine while you're treating them for their opioid use disorder, how are they buying that? They're buying it with the drugs that you're writing to treat the disorder. So we have to be very pragmatic about our approach. So that leads me to treatment. What do we do? All right, so we've identified it. We know what the cause is. Generally, I would say the biggest area of prevention at this point in time is going to be to support your law enforcement, but very specifically, to not support those providers in your community who are doing bad. And if you don't have the expertise to determine who's doing bad, then what you have to do is let somebody who has that expertise determine that. And at the state level, we're working on what we call medically assisted policing, so that we have basically a physician and a pharmacist that's working with the state police or local law enforcement to review the cases, because what I don't want to do is take out physicians who are really trying to do good work and they just need more help. You know, they just need somebody to help educate them on something, or a support to call when they don't know what to do with the patient. Because if we remember back in the late 1990s, we actually had literature, now found to be fake, oddly enough, that showed us that it was okay to prescribe opioids, that OxyContin was not addictive. Are you crazy? Come on. That's what it said in the Journal of the American Medical Association. Huge prospective randomized trial that shows you can write opioids for a large number of people with less than a 1% chance of addiction. Yeah. The 3 lead authors, 2 have lost their medical license and 1's in prison. Purdue Pharma, $100 million worth of their bank account. This is a reality that we have to live with, because this happened back in the late 90s and early 2000s, and it really created this pain is the 5th vital sign. You have to treat pain no differently than blood pressure, which is fine, but they forgot to follow that up with education. And then all of a sudden we're like, oh, opioids are awesome. You just give it to them and they're super happy. And the problem with opioids is that it not only treats pain very effectively. If I have a kidney stone or a broken femur, please, feel free. I'll take some. But what it also does is it covers up that suffering. So we really don't know what we're treating. So even if we have a patient who complains of pain and I give them an opioid and they say I feel better, I still don't know if what I was treating was pain or their life suffering that kind of goes along with that. And this becomes important because the patient gets very frustrated and angry because if you get that much of a dopamine bump, that's a happy chemical. So all of a sudden you're happy, and you, my doctor, are going to take away my happy? I hate you. You're horrible. You're trying to kill me. I'm writing a complaint. That should be a sign. I never have that conversation about lisinopril. Like, nobody has that argument with me, I'm going to change your blood pressure med, and they freak out. You know, they don't show up 2 weeks early for the prescription for their, their diabetes med. I mean, they don't. I mean, the reality is this is a medication that has an emotional connection that other things don't. And if it pushes on dopamine, like all those drugs that we talked about, all the drugs of abuse, then it has that ability to create that emotional connection so that people will not act rationally in their approach to either obtaining or using the drug. And so that is where we start getting into what we need to do next. So over the last 3 years, I've been working pretty closely with the state and trying to build what is the evidence-based approach to all of the substance use disorders, not just opioids. I mean, opioids are the biggest one now, but if we build a good system of treatment for opioid use disorder, then that will absolutely help us with the next coming wave of benzodiazepine disorder, followed by marijuana use disorder, and whatever random new drug gets made that makes you high at that point that we see in all the movies. There's always some new one, right? But there's always going to be something out there. We've abused drugs since we've known substances mess with dopamine. I mean, I think that it was in Genesis, it talked about Noah getting drunk in a tent and having to be dragged out. I mean, this is old. This is not a new thing. So as we start to look at these aspects of what we're going to do, building a good system at this point is of the utmost importance. And it's not just to treat one issue. It's building a long-term sustainable system so that the next generation and the next generation get appropriate evidence-based care for the treatment of addiction. So what is that evidence-based care? I'm going to focus on opioids, and I'm happy to answer questions about other. But specifically for opioids, when it was stated that opioids are different than other drugs and how they approach the brain, the answer is yeah, that's very true. The end product is all dopamine, but each of them work on a little different aspect of the brain. Like marijuana works on the cannabinoid system, and that's a fine-tuning system in the brain that messes with how we react to emotional status, and it can do everything from how your bones heal to how your stomach works and all of these things. So it's all over the place. Opioids work on the suffering axis. So if you've had a bad early life, a bad current life, or pain, and all of this other stuff, it works on that, which begins to create a behavioral pattern that you will do anything to obtain that, even over and above the dopamine. So if you have no dopamine and I can't get you to stop craving, what does it seem logical to do? Raise dopamine. We do this for serotonin for depression. We do this for norepinephrine in a different type of depression. Why wouldn't we do this in addiction? Do we have the capability to do it safely? Yeah, absolutely. We have two drugs that indirectly raise dopamine. That is buprenorphine and methadone. How many people have a negative emotional context of either of these drugs? How many have ever said, I hate those drugs? Why do we hate a medicine? Isn't that weird? It's like a chemical. Like you point at a book and go, I hate that. Or is it more about how it's utilized? Right. And so if we look at the evidence of how it's utilized, what we're going to find is that treatment centers around the state or the country, there is a very heterogeneous approach to how these are utilized. Everything from, I found doctors that will write for 32 milligrams of Suboxone with no therapy on the side, and they write for 90 days at a time. Is that helpful? No, half that crap's getting sold. I mean, this is what's happening. What about the person who's like, I don't want to treat anybody, I'm not writing any of these drugs. It's all going to be, we're going to sit down and we're going to really talk through this until we just hammer it out. Success rate, 8%. That's not very helpful. Abstinence-based approach for opioid use disorder, to start, not to finish, but to start, is about 8%. What about, so I'll talk about what we do at our clinic. So We average a dose between 8 and 16 milligrams, which if you're not a prescriber, that doesn't mean anything. But it's the dose that the evidence shows actually stabilizes dopamine enough so that therapy works. And then after, remember we talked about at 1 year, it's no different than 30 days, 60 days, 90 days. We don't even talk about getting off of the medication until about 18 months or 2 years, which is when we finally start to see that part of the brain heal. In those patients, it's going to heal. But just giving them a medication is not going to fix it. Writing a prescription got us into this problem. Just writing a prescription is not going to get us out. It's building an appropriate system of care and utilizing these drugs in a way that can have accountability and in a way that we know is being utilized so that the patient is increasing their function. Not just they're telling you they're okay. Oh, I feel so much better. But you're still laying on the couch all day, not doing anything. That's not really better. Better meaning I need you to show up. I need you to be active in your therapy. I need you to be active in your approach. So the problem with methadone and buprenorphine is that we see this as a completely different approach to treatment of healthcare, which is weird because this is the same approach that we've used for diabetes that's pretty successful, which is we write a medication, we do a ton of nutritional therapy, we give them cooking classes, we have somebody come home and show them how to use it, we do all of these things for people with diabetes. But we don't do those things for opioid use disorder, which is a chronic neurobiological disorder. Not some bad decision thing. It's not like, you just need to figure it out, man. Because that really doesn't work. That equals basically mortality in this group. So what about those patients who are really motivated? So let's say we don't want to use buprenorphine or methadone to stabilize dopamine. Let's say that naturally it bounced back pretty fast. So maybe they didn't use that long or they didn't use that much. And it bounced back pretty good and they're motivated to get better. Do we have meds for that? Absolutely. We have naltrexone. It's a shot in the butt that lasts for 30 days. Right? That's great. It's not the magic bullet because that works really well for some people. Buprenorphine works really well for some people. Methadone works really well for some people to initially stabilize. But what happens after I give that dose of medication? So I wrote the state guidelines for medication-assisted treatment, and in those guidelines, the data is very clear. You can use a medication to stabilize the dopamine axis of the brain so that therapy starts to work, but you have to do high-intensity therapy. High-intensity therapy is minimum once a week for 6 weeks, once every 2 weeks for 8 weeks, followed by monthly if everything goes well. For my patients that enter, we have very few people that just march through that because they'll walk in and they will have relapsed. Relapse is a part of early treatment. That's just a part of it. It shouldn't be something that's angry or frustrating. It is a part of the disease. And you shouldn't malign someone because they're not perfect, because we do not put people in jail for buying Krispy Kremes when their blood sugar is 500. We don't do it. But they're just as impaired on the road many times if their blood sugar goes to 50 or it's at 600. If they have a safety-sensitive job like a physician or a police officer or a pilot or a lawyer, these are things that, we don't hold them accountable for those things. We're like, oh, that's a total bummer, your blood sugar was 50. But we can calculate carbs and give exactly the amount of insulin, and they just needed to do a little math. There's even apps that calculate your donut. And you put it in, and it tells you how much insulin to use. So we need to start understanding that if this is another chronic disease, then we should treat it like other chronic diseases that we've had successful outcomes, which is we use medication to stabilize it. We use therapy to solidify the thought process so that they don't automatically flip to, I have a conflict, I need a drug, or I feel sad, I need a drug, or I am scared, I need a drug, or my life sucks, I need a drug. What we do is have to change that from a cognitive behavioral therapy standpoint to, my life sucks, I should fix that. I'm really sad. Why is that? To change how they approach this is what the whole basis of therapy is. And I have yet to find anything better than what was created back in the 30s for ongoing recovery-oriented systems of care, which is a 12-step modality of group approach, which is how do you help yourself? That is not the fix-it for the beginning. I have found that fails miserably very early in opioid use disorder. But for a medium and long-term outcome, I've found nothing better. Because this is a chronic disease. So let's say I wean somebody off of this med in 2 years, and we've done all this cognitive behavioral therapy and motivational enhancement therapy and dialectical behavioral therapy and motivational enhancement, all the stuff that we need to do. When we add that in, and then we drop them off at the pool, good luck. That doesn't work. So once you have the disease, you always have the risk of the disease. And this mirrors very closely type 2 diabetes. So type 2 diabetes, you have a genetic predisposition, just like an addiction. You maybe eat a little differently than you should, / you tried your first beer. You gain weight. You use a little more than you should. You get to the point where you have insulin insensitivity, / you have tolerance to a drug. You get to the point where you need a medication to maintain your daily existence, metformin, insulin, the drug. What do we do for the people who are overweight, don't exercise, and eat poorly? We write them medication, right? Because it's safer. It's safer than not writing a medication because they're going to have diabetic ketoacidosis and go to the hospital and their foot's going to rot off and like all that, they're going to go blind and all the stuff that we know happens with diabetes and they're going to have premature death. What do we do for opioid use disorder? Get better. Say no. I mean, these are things that just haven't worked and we know that. What we have to do is the same basic approach. We have medications that will replace the very dangerous medication. So a methadone clinic, let's say you just give someone who's injecting heroin and you just shove them into a bad methadone clinic. All right, just a bad one. You shove them into a bad methadone clinic, what you're going to get is somebody who has a less risk of hepatitis C, less risk of HIV, less risk of criminogenic behavior. Those things all happen. That's called risk reduction. Is that addiction treatment? No, it's just risk reduction. So we should not be okay with just risk reduction. We should know that that's a reality because we get those same basic benefits when we use buprenorphine or when we use Vivitrol for a patient who's motivated. When we do those things, we know that we're decreasing their risk of incarceration and death and issues with the people around them. But once we add the appropriate therapy and know that at a year or 2 years we should start talking about, let's see if we can wean. Let's see if your brain is healed. Let's see if you're making your own dopamine for the right reasons. If we couple those things together in that approach, what we find is that 75% of people are able to get off of medication long term, able to maintain that level of sobriety. So let's say you've been clean or sober for a year and you have a bad weekend. Why is that a catastrophic failure of management? Why do we have to start from scratch? That's a bad day that we need to work on and focus on and figure out what that cause and effect was. Why did that happen? We should not have to catastrophically start over. Well, you got to go back into what they perceive early as jail for 90 days, for this. This is not the approach that we should be taking. We should risk evaluate. We should look at the cause, the root cause of what happened, and help them with that. So the biggest thing that I think we have to fully understand is that we know the neurobiology of this disease, period. This is not up for debate anymore. This is math. This is science, and this is data. We have evidence-based treatments that when we apply the right treatment to the right patient at the right time, we have 65 to 75% positive outcomes. We have prevention that we know. We find those that are bad actors, and we get them out of our state. We try to get their license completely removed. There are a lot of barriers to that. I mean, people in my region, I have 7 counties that I'm in charge of, for substance use disorder over on the west side, and all the doctors and people in that, they know that I'm coming after them. They should have that same feeling of somebody looking over their back here. It's not to be mean. It's not because, I write opioids. I'm the chief of pain medicine. There are patients that I've identified that have chronic, severe pain that an opioid really is the only thing that I can do for that patient. But there's a responsible way and an irresponsible way to write those medications. There's holding yourself and someone else accountable, and then there's not. There's lack of education, and then there's criminogenic behavior from a doctor perspective. And we need to be able to define those with very bright white lines and then go after those with criminogenic behavior with impunity. They should never be able to write a prescription again. In fact, they have lost they should lose their doctor card at that point because we took an oath, right? We took an oath to take care of patients, to take them first, and to do no harm. And we have done a massive amount of harm in this population, and it's inexcusable at this point. There's too much data, science, and math to tell us otherwise. So as we move forward with understanding how we build good systems of care, how we pay for those systems of care, we need to focus purely on the evidence because that's what we have. Does the evidence treat 100% of people 100% of the time? No. That still lives in the art of medicine. And the art of medicine is, I don't know, let's see what this works. I mean, I try to romanticize it, but the reality is like, this seems logical, let's try it. You know, we do that all the time, but we have to understand that as we start to find these people that are the exception to the rule, why are they the exception? And we drill down on that, and we try to figure out how we build a system around the exceptions to the rules, because all my patients think they're the exception of the rule. They're like, I'm that 1 in 10 million that's not going to work on. I get that, and I'm like, wow, I got a lot of those in my clinic. So if we walk away with those basic concepts, if we know how to identify it, we know what to do when we find it, and we know what to do to maintain it afterwards, we are the only ones stopping that from happening. And it is our emotional prejudice about the disease. It is the way in which we have stigmatized this patient and the treatment pathways for these patients. And it is inexcusable as a society to let our illogical emotional connection to the treatment of a chronic disease get in the way of people getting better. And so I will challenge you to disconnect the emotion from this disease so that we can treat it, so that we can get people to understand that they don't have to hide in the shadows. You know, nobody hides in the shadows when, you know, grandma's getting treated for diabetes. I sit at any restaurant and hear 7 conversations about so-and-so's insulin or Bactrim or this. I mean, it's like I can't go anywhere without somebody talking about medicine. So what we have to do is do the same thing for addiction that we do for everything else and understand that it is what it is. Greater than 37 million people in the United States currently have a significant addictive disorder. And let's just go treat it. Because we can do this, but it requires all of us to do it. Because I've been yelling for quite a while and throwing a lot of rocks and trying to help where I can. And I need all of you guys to do the same thing, because I have found a lot of people who are doing the same thing and working together with a cohesive language, a cohesive approach, is the only way that we actually solidify a system instead of just putting another Band-Aid over something for long term. Thank you. So I think we have time for questions.
Thank you, Dr. Waller. Just to let everyone know that Dr. Waller is not going to be available for the question and answer panel later today, so this is the time to ask questions of him, if you have any. Yes.
Yes. So I didn't get in because we had a short amount of time, but we have kind of what I call the haves and have-nots. And it's not money, it's dopamine. So we have those that started later and used less. And so if we look at the health professional recovery programs, like for doctors, pilots, lawyers, safety-sensitive jobs like nurses and that, these are people who didn't start at 12, didn't have a real deep utilization in high school, and were able to accomplish within college and move forward. Those are patients who have solidified that dopamine enough to where even if they start using later, they can generally regenerate it. This is a group of patients that we many times don't even need medication-assisted treatment because we can get that dopamine to be kick-started naturally on that. And that's why for like physician programs and those other professional recovery programs, we have almost 90-95% 5-year success without any medication. Now the population I see is different than that. Those are patients who are lower, and things like exercise and better diets and all of those things have been shown to absolutely naturally increase dopamine back to kind of normal levels over a period of time. It still takes a while, but at the same time, this other group of patients, you can give them all the juicers you want and have them run early, but if that neuron has actually been completely destroyed or is atrophied, you still have at least 1.5 to 2 years before they can naturally create that dopamine again.
Yes, there's 70% of people begin with prescription opioids, and I hear you talking about your efforts to see that physicians, medical doctors are operating within a better format and your enforcement. But what about the pharmaceutical companies? I'm not hearing anyone say go after the people who are making money off this.
Yeah, so that's
I hear people say let's go after the heroin dealers. What about the pharmaceutical companies?
So I will address that directly because internally I have the exact same emotion that you have. And I'm the chair of the Legislative Action Committee for American Society of Addiction Medicine, which means I'm in DC once a month, or I'm on calls or working in that. And this is a big thing that we have. The problem is that they have a significantly powerful lobby. For every one of me, they have 30 of me that are doctors, that show up and talk to lawmakers and talk about, look, this is not about the drug. It's just about, enacting, it's about continuing our current laws and surrounding this and about that. Because what the logic that like Purdue Pharma, who made OxyContin, would use is like, look, it's not the bullet that caused the problem. It's the person who held the gun. So why are you blaming us? That's the logic they use. Now, they buy that logic in DC. So this actually comes down to, if you want to go after pharma, a multi-billion-dollar industry, it requires legislation. And things that require legislation require legislators who are willing to go in and fight that fight and not be massively held accountable the next election cycle. I mean, that's a reality, because they get there, and if they go in to fight that fight, they're going to get really beaten and bruised. And that's a reality. It's not an excuse, it's just a reality. So you have to elect people who are perfectly fine with a 4 to 6 year stint and then basically being fired for doing the right thing. And that's where we're stuck on that. Yeah, they need to be held accountable. The government is trying to hold them accountable with some making them put in money into training and risk and education mitigation strategies and all of this. But for the death toll that it's been caused, it's a little bit crazy. And this is interesting if you look at the medication Vioxx. You might remember Vioxx. It was a non-steroidal medication. Without question, the best anti-inflammatory pain medication produced to date. Possibly was responsible for 2 to 3 early deaths of people in their 60s. Possibly. Completely pulled off the market. Well, what in the world is going on with opioids is killing thousands of people per year with unabated utilization. But yet for me, someone who writes buprenorphine, I can't take patients anymore because I'm at my 100 patient limit. And we use naltrexone, we use buprenorphine for opioid use disorder, and then I refer to a local methadone clinic that we work very closely with. And what can I do? And the funny thing is I'm board certified in addiction medicine, and I still have the same limit as somebody who's never taken more than an 8-hour class. I mean, this is stuff that's just not logical. And what have we done at the state to build new regulatory structures around regulating pain clinics? Right? I like how that really got better when I got the pain clinics. But that's the thing is, quote, pain clinics, just writing somebody doped isn't treating pain. I mean, that's the reality. So you can either prescribe it no differently than somebody on the corner, or you can prescribe it in a way that is therapeutic and responsible and increases function. And the drug companies have to be responsible for saying how to responsibly use this drug and training in that. I think they should be held as accountable as the tobacco companies. And they should have to dump mountains of cash into treatment facilities and capabilities and quintuple the block grant that we use to treat those underserved patients. I mean, that's what we need. And they have the money. I mean, they're not wanting for that. Purdue Pharma's about to have one of the biggest years they've ever had. Mostly still off of their now abuse deterrent Oxy. Which, by the way, as the utilization of Oxy went down, the utilization of heroin went right back up. I mean, it basically surpassed it. So we didn't see that. And as we start to clamp down opioids, if we don't build the treatment system around it, then we're just going to end up with a lot more dead people. I mean, because this is where they go. And it's not because they're like, well, you know what, I'm going to go to heroin because that sounds awesome. That's not what happens. They're freaking out. They're going into withdrawal. Their dopamine is low. They don't know what to do. They're in the survival mode. They show up to the person who used to sell them their Oxy. And what do they have? Heroin. They don't have Oxy, or they have Oxy, but it's $200, or for $10 you can get this little bag of brown stuff. You don't have to inject it. You can just snort this one. I'll give you this one for free. Don't worry about it. And they snort it once or twice, and then that's not enough. And then at that point, it's off to the races, and then you're basically shooting $10 bags of brown tar heroin. I mean, it literally flips a switch like that, and this is a problem. So we have to not only decrease the availability of the opioids, but we have to absolutely beef up the treatment capability at the same time, or we will have an even worse outcome than we currently have.
Questions from this side of the room for Dr. Waller? Doctor, I've got a question. How do you treat pregnant women with opiate use disorder?
Yeah, that's a great question. This is an area of our expertise. We see the vast majority of pregnant patients within our multi-county area. And so data science and math. If you are a pregnant patient and you are utilizing heroin, it will absolutely decrease the risk to that child to place you on either methadone or buprenorphine. So the question that comes after that, what does it do to the baby? Is the baby born addicted? No, because we define addiction based on behavior, and I don't see a lot of newborns out peddling for drugs on the street. You know? This is a problem. It is, when they're birthed, what is the one thing that significantly decreases? So let's say I have somebody on buprenorphine or methadone. They have neonatal abstinence syndrome, which is baby withdrawal, you know, whatever we try to call it, it's withdrawal from opioids. But you can also have withdrawal from tobacco, caffeine, SSRIs, all of these other things that are pretty commonly there, you can have actual withdrawal from it. Marijuana has a pretty significant neonatal withdrawal syndrome. But what is the number one way that I can decrease your risk of going to the neonatal ICU? Breastfeeding, something really basic, right? So what is the long-term outcome for these kids? Well, you basically cut the fetal demise, premature delivery, and long-term aspects of bad outcome by, what is it? You cut it by almost 70% by placing them on medication-assisted treatment, meaning buprenorphine or methadone. You can't use naltrexone in a pregnant patient at this point. But what we're looking at now is you put them on that, and we've tracked it. We have good longitudinal data for now 15 to 20 years of what that means for this kid. And what it means is that if mom's in treatment and the kid was born, they have absolutely no difference in outcome than somebody born without any of these meds. There's no difference in rates of early death, ADD, graduation rates, college attendance rates, nothing. So the long-term aspects of being on a medication, for a mom being on a medication during pregnancy so that we stabilize the disease, have these kids born closer or at their due date at an appropriate weight with appropriate capability of taking on nutrition, is without question the best thing to do. They are not killing their baby. They are not hurting their baby. And if you don't think that mothers who have an opioid use disorder don't have more guilt than anybody in this room every morning when they wake up, then you haven't really sat down and talked to them. So adding that guilt on by saying, you know, you're hurting your baby is the worst thing you could do. In fact, I would say that when you say that, you have just increased the risk of the death of that child every single time. So good job. This is frustrating because I have people that will come to me that are educated, that are knowledgeable, that are smart, who somehow have created this emotional context of this disease to the point where they are willing to put the health of that child at risk because of the way they feel about a medication. Not okay. Mom being in treatment on buprenorphine or on methadone, absolutely the right thing to do. Do we need to make the methadone clinics better at what they do? Heck yeah. Do we need to make the people who write buprenorphine better at what they do? Absolutely. But this is through a strong licensing and regulatory development within the state, which we're currently working on, because accountability is number one. And as we do this, pregnant patients have to get treatment, but what percentage of OBs actually screen? Less than 10%. What is the number one cause of premature delivery now? Drug use disorder. We test for HIV and hepatitis C and like these metabolic syndromes that happen in 1 in a million kids. Neonatal abstinence syndrome is filling up our neonatal ICUs, and for our patients who we treat, their average stay, even if they go to the NICU, which is actually cut by 60% when they're on the medication-assisted treatment as compared to not, is 2 days after the normal stay as compared to 2 weeks after the normal stay. So it not only improves the rate of baby going home with mom, the cost of $7,000 a day in a NICU, but also has no long-term adverse effects on this child. And we know that if mom is stable and being treated appropriately, then that absolutely is better. And I love, this is my favorite population to treat because without question, this is stopping the, quote, cycle that we always talk about. Because if I can get mom stable and I can get kid home with mom, then we now have a family. I mean, this is pretty cool. So we've now started a family, and we don't have a mom whose kid's been ripped out of their hands because they didn't get appropriate treatment, and a kid now in the foster care system or, you know, with some family member who has just as many problems, you know, and we can keep tabs on that. So this is a really important aspect and is absolutely one of the number one things we can do for prevention is to treat mom.
Thank you, Doctor. We've got time for one more question.
Yeah, our auto refill program is being looked at. I didn't realize that was an issue until my own blood pressure and thyroid medication. I take what I'm supposed to. I don't skip, so there's no reason I should end up with extras. And I got to the point where I had more than a month extra. And when I talked to the pharmacist, she said that that is an issue. And even if you take it like you're supposed to, you end up with extra medication. And to me, until it happened to myself, that's a component of this as well. People get extra medication because you get that alert, hey, we got a prescription for you, come down and get it.
Right. So there are three aspects to that. Luckily, people aren't generally crushing and snorting levothyroxine, so that's good. But they do abuse it, oddly enough, as a appetite suppressant. But Wellbutrin can be abused. It can be crushed and injected. By the way, it causes a horrible vasculitis. But when we start to look at this, there are three components to that. So the first component is we shouldn't be writing as many from the get-go. So if you go in and you have a sprained ankle, you don't need 30 days worth of opioids. If you go in and you have a dental surgery, you don't need 30 days worth of opioids. I had a neck surgery a couple of years ago, and funny story, too long to tell now. But when I had that surgery afterwards, they were willing to write me for like a month's worth of meds, and I'm like, I'm okay. I don't really need it. Some ibuprofen should be fine. And they were like angry at me. It's just like, I can't believe you're not going to take this script home with you. And this is the problem, is that we have these HEDIS measures, which is a group that oversees hospitals, and Joint Commission measures, which oversee hospitals, that if you don't send a patient home with a treatment, with a prescription for a pain medication, you actually get knocked off. So instead of writing somebody for 3 days and saying, call me if you still have pain, they write them for 30 days so they don't have to get that call. Because most surgeries are paid for in a bundle, which means that you get paid for the surgery and all the follow-ups associated with the surgery one time. So if you have 10 extra follow-ups for that kind of close monitoring, then you're basically not getting paid for any of those. So we have ended up in a situation where we have absolutely gotten what we pay for, from a medical healthcare standpoint. The Prescription Drug Monitoring Program, or the PDMP, or in Michigan, it's the Michigan Automated Prescription Service, allows us to look in and find out if someone has gotten another prescription for a controlled substance. The accidental refill for controlled substances happens very little now, because if it's a Scheduled 2, Schedule 3 drug, which is basically all addictive drugs in Schedule 2, those that are higher risk are in Schedule 3 for the DEA. Those are scrutinized to a pretty big degree right now, and so they don't allow for a 90-day supply. You can't write. It's got to be a 30-day supply. Even Norco now has gotten moved into Schedule 2, so it requires a new written prescription to be taken to the pharmacy for that, and we track it. One of the problems is I think, and I think our task force I was on with the governor's office, is we think that every physician should have to check it, mandated that they have to check it. The problem is the system isn't built so that we can do that. If everybody did, it would crash. And so we have to rebuild the system, which means that we have to appropriate cash to build the new system for about $3 million. So trying to appropriate cash to build something that increases safety / prevention of use is not that easy sometimes with state legislatures. So these are things we're having to push through and get done. So these are things that I think are really important. As easy, that's easy, right? That should be really easy. Don't give them more than they need. I mean, that's a pretty straightforward, but there are a lot of barriers, oddly, even in front of that. So being involved in this, being very knowledgeable about it, and knowing that we're dealing with a chronic neurobiological disorder, going after those people in your community that are doing it wrong, and talking to your lawmakers at the state and the federal level about what are you doing? Hold them accountable, because they absolutely have the capability to write laws and approve regulations to get this done. And if they're not willing to be accountable, then get them out. There are other people who will do this and be very accountable. And most of the ones I've met with are actually just as worried. They live in these communities. They have friends. A lot of them have family. So help them, motivate them to do it, and back them up to do it if they're doing a good job. And I think that all of those together, we will get this, and it will be settled in for long term rather than just let's put the Band-Aid over and be done.
Thank you, Doctor.
Yeah, thank you.